Hi, Susan. Am I audible?
Hi, doctor. Yes, yes, you are. You are. So we'll start in another 5 minutes.
No, sure.
Wait for more people to join.
Sure.
Hi, everyone. We will wait for another 5 minutes for more people to join. Meanwhile, please follow the guidelines on the screen so that we can have a smooth session today. Thank you. Hi, everyone. Welcome to this session on lupus and kidney. So, this is part of a month-long series organized by Lupus Trust India Karnataka chapter, where we are interacting with different doctors from different specialties who are treating lupus patients. And just a bit about what Lupus Trust India is. We are the only patient-led advocacy and public charitable organization for lupus patients in India. So, some of our core mission includes campaigning for awareness, providing financial aid to disadvantaged patients, and also advocating for policy changes and community support. Yeah, sorry, my screen was still on share. So that's about who we are. Now I'd like to extend a very warm welcome to our guest speaker, Dr. Fahad, who is also my doctor. His expertise lies in treating glomerular disease like lupus and treating transplant, dialysis, acute and chronic kidney disease, and stone disease. So he's published several research papers and won multiple awards, including the Dr. H.L. Trivedi Gold Medal for ranking first in the All India DNB Nephrology exam in 2022. And on a personal note, he's been an absolutely brilliant and supportive doctor, especially during my dialysis and transplant. And to quote a famous American physician who says, the secret of the care of the patient is to actually care for the patient. So I think Dr. Fahad really lives up to this for all his patients. So yes, thank you so much, Doc, for joining us and giving us your time today. We're really eager to hear from you.
Thank you, Susan. Thank you for that very kind introduction. And welcome to everyone who've taken their time out on a Sunday evening to join this discussion today on lupus and kidney.
Thank you, Doc. So we'll get straight to it. The first section, we're going to discuss about the diagnosis of lupus nephritis. So according to the National Kidney Foundation, 1 in 3 lupus patients have lupus nephritis at the time of their diagnosis, and 5 out of 10 develop nephritis over time. So, could you talk about how late diagnosis impacts, this aggressive damage on kidneys, and also what actually leads to kidney involvement for lupus patients, and what are the symptoms and red flags to look out for? And also how this can be prevented. I know that's a really packed question, but take your time to answer that. Yeah.
Yeah, so lupus, as you know, is a disease which is very common in the reproductive age group and especially women. So, as you rightly mentioned, 1 out of 3 would have their kidney involvement, that is lupus nephritis. And generally, this happens within the first 2 years of the illness. So, when you say that diagnosing it late wouldn't be late with respect to your duration of illness. In the sense, suppose since many of those who have joined here today are patients themselves, you would know that you can have a lupus flare without having your kidneys involved. So if you had to take 100 patients who had a lupus flare or lupus, around 40 to 50% of them would have some form of kidney involvement. It's not necessary that everyone has their kidney involved. Now, one of the reasons why some of you would be following with a rheumatologist, and last week I believe you must have had a discussion with Dr. Dharmanand also, who joined here. Even the rheumatologist checks you repeatedly or regularly to look at whether your kidneys are involved or not. Now, one of the subtle markers, at least clinically, that is with respect to symptoms, would be leg swelling that you notice. And this leg swelling doesn't have to be right in your face where your shoes don't fit you anymore. It can be simple things like taking a cab ride for an hour or a flight, and you notice at the end of the journey that there is some amount of leg swelling. The other thing is frothiness in the urine. Now, frothiness in urine is a symptom which has been glorified both by the doctors as well as the patients. One thing to understand is Having frothy urine doesn't necessarily mean that you have protein leakage. Froth in the urine depends on whether you're using an Indian washroom or a Western washroom. It depends whether you are sitting and urinating or standing and urinating. It depends who has used the washroom before you. It also depends whether your maid has used Harpic or not, so a detergent or not. So, froth in the urine should lead to urine testing, but it should not be presumed that it is 100% warrants or necessitates that it means proteinuria, that is protein leakage in the urine. So froth in the urine should lead to checking your urine for protein. So if you're following up with a rheumatologist or a nephrologist, creatinine and urine routine to look for urine protein as well as urine red blood cells, these would be the three tests. And the fourth subtle marker would be blood pressure. So blood pressure, unless you don't check it, you wouldn't know whether you have high blood pressure or not. So it's very important that you get these four things tested to understand whether you have renal involvement or kidney involvement because of lupus or not. So that is one part to your answer, which was how do you look for kidney involvement. The second thing is, if you realize the markers that I mentioned to you, creatinine, urine protein, and blood pressure, all these three require active intervention and active effort for testing. So suppose you have not tested any of these, they could lie indolent and could persist for a prolonged period without you realizing that you have them. So that would lead to a late diagnosis. So suppose your lupus happened here and protein leakage, high BP, high creatinine has happened here, but you've not tested and you detected here. So you've lost this much time. And if the lupus persists with time, it leads to scarring. It's just like if you have a cut on your hand, it leads to bleeding, it leads to healing, but it leaves a scar behind. Similarly, lupus in the early stages, it doesn't necessarily need to be very aggressive. It could be slowly eating away and attacking your kidney and causing fibrosis of these filtration units that you have. And that would lead to chronicity. So that lost time, suppose the creatinine was normal and 1 year, if you have delayed it, you could have a higher creatinine, more protein leakage, and lesser chances of recovery back to normal if you have delayed the diagnosis. So it requires active effort to look at these four things, and that would help you detect lupus early and treat it appropriately.
Right. Thank you, Doc. So in terms of actually diagnosing this medically, could you go through some of the diagnostic tools or processes to diagnose lupus nephritis? And could you specifically talk about kidney biopsy? Why is it necessary? How often is it needed? And to give a little context, a lot of patients have experience a lot of anticipation and anxiety when it comes to getting biopsies done. Some of them have had painful experiences as well. And also just the way it is communicated, sometimes it sounds really scary. So could you talk about diagnosing in general and also kidney biopsy specifically? I think we lost him. Probably a network issue. Just give me a minute. Let me check with him.
We would request.
Sorry.
Yeah, no worries, Doc.
Sorry.
No problem. No problem.
1 second.
Recording in progress.
Yeah, would you like me to repeat the question, Doc, or are you?
Yes, you would have to repeat the question.
Yeah, no worries, no worries. So I was asking if you could talk about the process of diagnosing lupus nephritis. the tests and all the blood work needed? And also specifically, could you talk about kidney biopsy? This particular procedure, a lot of patients have a lot of anticipation around it and anxiety, and some have had painful experiences. And overall, sometimes the way it's communicated sounds really scary. So could you talk about diagnosing and about kidney biopsy?
So lupus nephritis, technically to diagnose it, you don't need a kidney biopsy. So, I mean, contrary to what has been told you before, see, for example, if you have systemic lupus erythematosus, that is SLE, with either deranged creatinine or a high protein level in the urine or blood in the urine, along with blood pressure, it's already established that your kidneys are involved. So, to diagnose lupus nephritis per se, you don't need a kidney biopsy. However, to stage your lupus nephritis, because there are various classes to the lupus nephritis, many of you may have uh, undergone a biopsy here and know that you are either class 3 or class 4 or class 5 or a combination of them, 3 plus 4, 3 plus 5. So, to understand which class you belong to, a renal biopsy is required. Now, a renal biopsy per se is a 5-minute procedure. However, just like when you have a cut on your hand, which can lead to bleeding, putting a needle into your kidney does carry the risk of bleeding with it. Now, if you have normal renal functions and the biopsy is just being done to establish why there is protein leakage and blood in the urine, uh, the biopsy is relatively safe procedure with chances of bleeding requiring blood transfusion being anywhere between 2 to 3%. Severe bleeding, which is requiring invasive interventions to stop the bleeding, are less than 0.1%. So biopsies over the years has become a safe procedure because we use ultrasound now to locate your kidneys, see the track of the needle, where it is exactly going and what part of the kidney is it actually puncturing. So it's a very common outpatient procedure where the procedure per se takes 5 to 10 minutes, but we keep you in our daycare facility or in the hospital at least for 6 hours post procedure to monitor for any sort of bleeding or complications that we could encounter.
Right. So you touched upon the different classes that, lupus patients are diagnosed with. Could we dive deeper into that? Because sometimes there's a lot of confusion between class and stage. Usually stage is used for, classifying CKD, and then classes for these lupus nephritis classes. So 1, 2, 3, 4, 5, could you talk about how these are defined and the level of damage and also the corresponding treatment that's needed?
So just starting from basics again, the 4 things that I told you: creatinine, blood pressure, protein leakage, and blood in the urine. Discard blood in the urine because that is more of a symptom or finding in the urine, which helps us with the uh, to establish that the kidneys are involved. Wouldn't help us know the severity because across all classes, be it class 1 to class 6, you could have blood in the urine. But if you have a higher creatinine, a higher blood pressure, more protein leakage in the urine, chances are that you are class 4. Amongst all the classes, class 4 is the most aggressive, which means that lupus involvement in the kidney would be most aggressive if you are class 4. Class 3 could have normal creatinine, lesser protein leakage, and lesser degree of hypertension, that is higher blood pressure. So class 3 and class 4 are the most common classes that are encountered in an active lupus patient. If, as I mentioned, there has been lupus nephritis going on for a long time, which hasn't been diagnosed, and instead of diagnosing it here, you diagnose it here, you'll have a lot of fibrosis that has happened in the kidney, and you could end up being class 6, where there's a lot of scarring in the kidney, less lupus activity. It's like the lupus is burnt out. The kidney has been severely affected up to a point where there is no reversibility. So that would be class 6. Class 5, on the other hand, is something which is more protein leakage dominant. Normal renal functions, normal blood pressure, but lot of protein leakage, lot of leg swelling, lot of overall swelling of the body, and protein leakage where you could be leaking 5 to 10 grams of protein a day if you have done a 24-hour urine protein. So class 5 is more protein leakage dominant. Class 4 is the most sinister, where the lupus activity is at its peak, its maximum. You could, as I reiterate, higher blood pressure, higher creatinine, and protein leakage. Class 3, milder of the two. Class 1 and 2 wouldn't warrant aggressive immunosuppressive therapy. So class 1 and 2 very rarely encountered on a kidney biopsy, because you could get away with treatment of the extrarenal symptoms itself. The treatment that is given for them takes care of lupus class 1, class 2. I think there are a few questions also in the chat. We'll take them now itself, because I
sure.
think because it maintains continuity also. Haripriya has asked, how does lupus nephritis class 4 affect pregnancy, especially for patients with hematological involvement like anemia, pancytopenia? So lupus, if you have active lupus nephritis class 4, we would strongly suggest you to not get pregnant. So that is if your lupus class 4 is active. So again, if you have had lupus nephritis, we allow you to get pregnant if you've not had a lupus flare for the last 2 years, you have been on stable immunosuppression. Your immunosuppression, for example, if you are on MMF, that is mycophenolate, which is a commonly used medicine, has been switched to something called azathioprine or tacrolimus for at least 3 to 6 months. And after that switch, you still have a protein leakage of less than at least 500 milligram per day, with easy to control hypertension on 1 or 2 blood pressure medications, with an overall creatinine of less than 1.5. So if your creatinine is more than 1.5, irrespective of the etiology of kidney disease, so I'm talking about chronic kidney disease now. Generally, if your chronic kidney disease and creatinine is 1.5, we do not encourage our patients to get pregnant. Okay, so I hope that answers Haripriya's question. What could be the frequency of renal biopsy? Now, there are 2 schools of thought. One is you do a biopsy at the diagnosis, and you find out that they are class 3 or class 4, and you give them appropriate treatment and monitor the urine routine and see for recovery. That is one school of thought. There's another school of thought where you give appropriate treatment, and after completion of the treatment, when you are going to start, consider withdrawing immunosuppression, you do a kidney biopsy to see where you stand. Because clinical presentation and pathological presentation are not always concordant, which means if your creatinine is well, protein leakage is well, blood pressure is well controlled, you would assume that the biopsy would show that, yes, okay, the lupus is under control. But studies have shown that that doesn't necessarily go hand in hand. You could have these 3 parameters well controlled, but your biopsy still showing activity of lupus, which would necessitate you to again prolong your treatment. So that discordance is seen in 20 to 30%. So I am of the opinion of repeating a biopsy after a year or 2 of treatment to see where we stand with respect to the pathology and kidney involvement. So that would be the answer to Gaurav Kar.
I'll just interrupt you. What we do is we'll follow the flow of the questionnaires that we have, and then what happens is a lot of questions are repeated. So we'll kind of club it together at the end so that we can save time as well. Yeah, thank you so much for answering this question.
Sorry. Yeah.
Oh, no worries at all. Thank you. Yeah, so now we move to the second section of the session, which is around the treatment of lupus nephritis. So could you please go over like the typical treatment protocol for a patient with lupus nephritis, and how often are these, kidney function tests needed?
So all these are tough questions, yeah. Like, I mean, I given the exam 4 5 years ago. Again, you're questioning me on these. But yeah, anyway, jokes apart. So, what are the treatment modalities? Now, that again depends on which class you are and how aggressive your lupus involvement of the kidney is. So I don't know how many of you have undergone a kidney biopsy, but I'm sure your doctors, whoever has read the biopsy, at some point would have mentioned something called crescents in the in the biopsy. If they have not, crescent is something which shows that the lupus involvement in the kidney is very aggressive. And the first dictum in lupus is to achieve remission at the earliest. You need to act fast, and they say you hit hard and hit fast. That is, if your lupus involvement in the kidney is quite aggressive, you need to go with the highest form of immunosuppression, and that is a drug called cyclophosphamide. Now, there are various studies which have compared cyclophosphamide with MMF and shown that MMF is not inferior to cyclophosphamide, but these are studies done in a different ethnic population. For example, the African population, the European population. There are studies that have come out of India, but all guidelines and most studies show that if you have aggressive involvement of the kidney in the form of crescentic lupus nephritis or a severe grade of renal failure, it is always advisable to use cyclophosphamide. If someone who has mild renal dysfunction, for example, creatinine 1.4, some amount of protein leakage, well-controlled hypertension on 1 or 2 drugs, you could still give MMF because cyclophosphamide has its own issues with it. As I said, lupus is a disease of mostly affecting women in the reproductive age group, and cyclophosphamide is a medication which affects your oocyte count in the ovaries. So you also need to, whenever you're giving this treatment, you need to be conscious and uh, aware of the fact that this woman at some point would want to have a family. So you need to take that also into consideration before you start treatment. However, having said that, as I said, if it's an aggressive disease, you better give cyclophosphamide, because if you treat inefficiently and inappropriately and not enough, they're anyway going to develop kidney failure, which would prevent them from becoming pregnant. So, of the oocyte number getting affected long term depends on the age of the woman, and I mean, the earlier the age group, the lesser chances of something called ovarian failure. So the chance of ovarian failure comes up to around 20 to 30%. But if I had to summarize this in a nutshell, you have cyclophosphamide, you have MMF. The more severe the disease, you give cyclophosphamide. That is, if crescents are there, or if you have a severe degree of renal dysfunction or renal failure.
Right. So you mentioned cyclophosphamide, which is a really powerful immunosuppression drug, and we also take steroids. And so a lot of these medications, like you mentioned, are a double-edged sword. Like they have great effects to treat the kidney, but they also have really potent side effects. So how does a nephrologist sort of make sure that this risk-benefit balance is maintained, and how do they actually also impact kidneys on the long term? For example, TAC has a chance of causing nephrotoxicity. So how do you maintain this balance?
See, our first priority is to get the lupus nephritis under control. And for that, you give cyclophosphamide, you give either mycophenolate. Steroids, obviously, is the baseline immunosuppression that you are going to give at least for a period of 3 to 6 months. There is now tacrolimus, which is there. Something called voclosporin has been introduced. Rituximab would have been used in many of you, not just from the lupus nephritis perspective, but also to control your extrarenal features. Now there are new medicines called obinutuzumab, which is a brother of rituximab. Yes, you are right in saying that it's a double-edged sword, and you suppress the immunity, it increases the chances of infections. But if you don't suppress the immunity enough, the lupus is going to remain active and it is going to eat away at various organs. So it's important you immunosuppress them enough. At the same time, to reduce the chance of infection, we give something called chemoprophylaxis, that are medications which reduce the incidence of infection, something called Septran or Bactrim DS, which many of you would be taking, which is trimethoprim sulfamethoxazole, which prevents urinary tract infections, a bunch of fungal infections, and I will not get into the type of infections that it prevents. Then antiviral medications are also given, something called valganciclovir, which some of you would be taking, or valacyclovir, which prevents herpes zoster infections, herpes simplex infections. So these two would be some chemoprophylaxis. Along with that, uh, some doctors do use antifungal mouth paint or antifungal tablets. So those would be to prevent the bacterial, viral, and fungal infections. Along with that, vaccination is something that is something which should be more frequently practiced. If some of you have not been vaccinated against flu, against the pneumococcal vaccine, against the herpes zoster, that is the Shingrix vaccine, it's important that you take it. While on immunosuppression, you should always not take any form of live vaccines. You should take the recombinant or dead vaccine. So yes, a double-edged sword, but we have enough medications to tackle the infection aspect of things, uh, as well as the immunosuppressive therapy that we're giving carries its own side effects like low white cell count, and MMF can cause diarrhea. So those are some of the questions I'm sure that the doctors who are following you up ask you repeatedly. So we do watch out for these side effects well as look at the infection aspect of it. But when you have lupus, our primary objective and motive and goal of treatment is to attain remission by hook or crook.
Yes, thank you, Doc. Um, could we also talk about the role of diet and lifestyle in uh, preventing further damage once we are diagnosed with lupus nephritis? And could you just talk about what the ideal kidney diet would be? Because there's a lot on the internet. There a lot of talk about the Brooke Goldner diet. She talks about how she reversed kidney failure with that. So there's a lot of information out there, but hearing directly from a nephrologist on what a kidney friendly diet is would really benefit all of us.
Yeah. My take on this, with no offense to anyone, is imagine if there was a diet to reverse lupus nephritis. Wouldn't at least 50% of you on this panel today be on that diet? I mean, uh, the primary objective is to control lupus nephritis, or whatever, anemia, thrombocytopenia. If there was a diet, wouldn't we be the first people to encourage that? It's an autoimmune disease where you have autoantibodies attacking various organ systems. Some people have multiple organ systems, some people have a limited organ system involvement. If there was a diet, most of you would be on it. Healthy diet, yes, is good for overall health, but not for controlling the disease. I'm aware of the paper where 3 patients were presented, and a Goldner diet was given, which was rich in kale and green leafy vegetables and things like that. But if that was the case, majority of the vegetarians would never have lupus to begin with. So I believe that immunosuppressive therapy is instrumental in controlling the disease activity, and it is a problem with the immune system where it is dysfunctional and you need to suppress it. Diet wouldn't be the best way forward. Having said that, diet does play a role when you have any sort of involvement, primarily renal involvement. Suppose your renal involvement is hypertensive, where you are a hypertensive, you would have to restrict your salt intake. Suppose you already have swelling in the body, you already have a lot of water in the body, you would not take in more water because your body is like a tank. If you are already water loaded and you take 4 liters, but you pass only 2 liters, then you are going to get waterlogged eventually. So water and salt would be the first things to control if you have lupus nephritis. Apart from that, whenever you have some sort of kidney dysfunction, the ability of the body to get rid of waste products or some electrolytes like potassium is low. So you wouldn't overload yourself on things like coconut water, banana, citrus fruits. It's the mango season now, so you wouldn't overload on, fruits. The second thing is many people ask, oh, I'm leaking protein. Should I restrict my protein? That again, the data for protein restriction and CKD comes from the West. What we need to understand is, as a society and Indian culture, we are not protein rich. Our diet is not protein rich. It's the Westerners who have like 3 lamb patties in their burgers, very protein rich diet. We Indians are more carbohydrate rich. We are more about roti, we are more about rice. So the recommended daily allowance for protein is 1 gram per kg for a normal individual. Now, if your ideal body weight based on your height was around 60 kgs, that would mean around 50 to 60 grams of protein. Now, 100 grams of chicken, boiled chicken, would be around 15 to 20 grams. One egg is around 6 grams. One egg white is around 4 grams. So I wouldn't advise my patients to restrict a lot on protein, because if you restrict a lot on protein, you also lose muscle mass, you become much weaker. So it's important, maybe around 0.8 would be the best protein intake for the day. I wouldn't necessarily restrict protein in the diet, severely restricted. They've done studies comparing 0.2 to 0.4 gram per kg, 0.4 to 0.6 gram per kg, and 0.6 to 0.8 gram per kg. And they found that the difference in the kidney function over these 3 categories is only 1 ml of GFR is 1 ml per minute 1 ml per minute, which is not necessarily significant. So I wouldn't restrict protein a lot. Yes, cut down on your amount of calories because you're already on steroids, and if you take a calorie rich diet, you will end up putting on more weight. Restrict your salt, restrict your water if you are if you already have edema, and if you are hypertensive, but not necessarily go for a green leafy vegetable diet and a lot of smoothies and things like that with the idea of controlling lupus. Green leafy vegetables and those shakes are good, but antioxidant rich, yes, but their contribution to controlling lupus activity, I am not too sure and not too confident about it.
Thank you, doctor. That was a really important topic to touch upon. Thank you so much. So once there's lupus nephritis, how does it lead to CKD? Is there a sort of predictive way of telling that it would lead to CKD and ESRD? Are there ways to totally prevent it or delay it? So could you talk about that?
Failure to control the lupus nephritis activity would lead to scarring and fibrosis in the kidney, which would eventually lead to CKD, which would eventually lead to end-stage renal disease. So if your lupus activity in the kidney at the time of biopsy shows, for example, class 3, class 4, sometimes class 3 can transform into class 4, it's important that those 3 parameters that I mentioned, blood pressure, creatinine, and urine protein, come under target levels. Failure to achieve those means that your lupus nephritis is not controlled enough and will lead to fibrosis and will lead to CKD and end-stage renal disease. There are various predictive models. A site called QXMD has various scoring systems to help you know what is the risk of reaching end-stage renal disease in 5 years and things like that, which looks at these parameters primarily and gives you a predictive model. But your take-home message would be, if these 3 parameters are not coming under control, then you have a higher chance of going into CKD and end-stage renal disease.
Yeah, thank you, Doc. So, last question for this section on treatment. The theme of our Lupus Month campaign is also on advances in treating lupus. So, could you talk about some of the latest medication that's come up specifically for lupus nephritis and how effective they have been?
So the future for lupus does look very bright, and there are various treatment options that are coming up. What you also need to understand is every medicine that is given to you affects a certain part of the immune system. And lupus, as we discussed, is a dysregulated immune system, and there are various limbs in the immune system which get affected. So the idea of all these lupus treatment is to find out which limb is not being covered with steroids or MMF or cyclophosphamide, and you use to inhibit that limb, so that a limb of immune system, so that you achieve appropriate immunosuppression. Now, rituximab has been around for the last 10-15 years. Now, there's a brother of rituximab called obinutuzumab, which has certain benefits with respect to its efficacy, the duration, and the side effects that it causes. Then there is something called voclosporin, which is a brother of tacrolimus, which has been introduced, where it's once a day rather than tacrolimus, which is twice a day. The need for checking levels per se is not there in voclosporin. Then there is something called belimumab, which affects the B lymphocytes, which is another limb in the immune system. The immune system primarily has B cells and T cells. So B cells is something that this belimumab affects. The Bliss trial that or study which came in looked at giving belimumab for a year and looking at the protein leakage levels, the creatinine levels at the end of 1 year. All these three medicines that I mentioned, two of them are not available in India yet. So, we're still some time away with these medications to come into the market. And right now in the US also, they're quite expensive. So over the years, I'm sure over the next 10 years, they will come into our country at affordable costs. There's something called CAR T-cell therapy, which modulates your immune system as a whole, which is used in refractory lupus nephritis. So the future for treatment of lupus nephritis is bright. There are a lot of newer modalities which are coming in, but I mean, only time will tell about their efficacy. And the more we use it, the more confidence we will have in those medications and use it more compared to the cyclophosphamide and MMF, which is routinely being used now.
Awesome. Thank you, Doc. This leads us to the last section, which is around lupus and ESRD, primarily treating dialysis and the kidney transplant process. So when do we decide when dialysis is needed for lupus nephritis patients? And how do you decide the best type of dialysis?
So dialysis indications, or when do we start dialysis, really doesn't depend on whether you have lupus or whether you have diabetes or whether you have any other disease which affects the kidney. The indications for starting dialysis are the same across all causes of CKD. So if you have a GFR of less than 10, or if you have symptoms related to the accumulation of these waste products. See, whether you are lupus or whether you are diabetes, when your eGFR is less than 10, your symptoms are more because of CKD, but more because of CKD and not because of your cause of CKD. So that's why the indications for dialysis remain the same across all causes. That is GFR less than 10, or if you have severe vomiting, loss of appetite, severe lethargy, lot of leg swelling, which is not coming down with diuretics like Lasix, which some of you may have used, or having breathlessness, or having lot of tingling sensations and itching all over the body, something called uremic pruritus, or that is uremic itching. So all of these would be the indications to start dialysis, be it diabetic nephropathy or be it lupus nephritis. Now, what form of dialysis would you start? There are two forms, that is hemodialysis or peritoneal dialysis. Most of you would have been, if you are someone who's undergone dialysis, would have experienced hemodialysis, which is done through a channel, be it a catheter in the neck or in the chest area, or a AV fistula or graft in your arm. And that is the most frequently used modality of dialysis. Unfortunately, peritoneal dialysis in our country as a whole, only 3% of CKD patients are on peritoneal dialysis. Peritoneal dialysis is done through a catheter put in your stomach area, that is abdominal area. It uses the peritoneal lining of the body to exchange toxins. It has to be done 2 to 3 times every day rather than hemodialysis, which is done 2 to 3 times a week. But yes, it gives you more flexibility because you can do this at home, either by yourself or by a caregiver. So there are two modalities of dialysis, and neither one pips the other when it comes to lupus nephritis. But as a practice in our country, we are more uh, uh, we use more of hemodialysis than peritoneal dialysis.
Got it. And specifically when it comes to lupus patients, can dialysis pose any unique complications? So I'm also speaking from personal experience where I experienced a lot of drug reactions, heparin, dialyzer. So is there any unique
No, so the
complications?
complications of lupus complications of dialysis in a lupus patient. Unfortunately, the complications that Suzanne also had during her dialysis days were not due to her lupus. See, by the time you have reached end-stage renal disease, the lupus activity comes down because CKD itself is an immunosuppressive state. Having said that, it doesn't mean you promote your patient to become CKD so that they become immunosuppressive. So your lupus flares, all of them, the chance of having a lupus flare is less than 10% when you're on dialysis. But having lupus and having and being on dialysis can increase the problems with respect to your heart. That is those something called cardiovascular complications. That is blockage in the coronary arteries. Those can become more if you're a dialysis patient with lupus, because lupus is an inflammatory state. It does affect the lining of your blood vessels all across the body, more importantly the heart. So that would be one complication which increases maybe 2 to 3 times compared to a person on dialysis not due to lupus. But as such, uh, I remember Susan asking me whether her allergy to heparin or allergy to the dialyzer, if she's more prone to it because of her lupus. Not likely.
Right. And, with dialysis, it really disrupts our lives. There's so much fatigue and a lot of water restrictions, etc. So, what lifestyle changes would you recommend to a patient on dialysis in terms of diet and just, regular life? And what kind of support should we seek during this time?
My most important recommendation to anyone who is on dialysis and who is the appropriate age would be to encourage them to undergo a transplant. So, if you have a willing donor in the family, irrespective of their blood group, because now transplant has uh, improved multifold, where we can do across blood group transplants, also would be to uh, encourage them to do a transplant. Because suppose you had three individuals aged 40 years. If the normal individual had a quality of life here, and the transplant patient would have a quality of life here, the dialysis patient would have a quality of life somewhere here. So there is a stark difference between the quality of life when you're on dialysis and transplant, because when you're on dialysis your whole life revolves around dialysis. I'm definitely not the right person to tell you about it, because some of you here have experienced it also. Your whole week revolves around, oh, when is my dialysis day? On dialysis day I'm going to be feel quite washed out and fatigued, so I'm not going to make any plans. And post that, you're like, I need to be aware and conscious of how much water I'm going to drink, how much salt I'm going to eat. So the lifestyle measures for a dialysis patient are again the same, whether you are due to diabetes or due to lupus. But the quality of life definitely for a dialysis patient is quite poor. And if you are in the appropriate age group and fit and have a donor within the family, my first and foremost recommendation would be to encourage you to do a transplant.
Thank you, doctor. That's a really important message because even in the group, there have been a lot of discussions on, whether transplant is really all that. And yeah, definitely.
So there's no doubt in my mind that the best three options for any dialysis patient is transplant, transplant, and transplant. So I couldn't emphasize it enough. And I mean, you have Susan, who is an example of the same. She's seen both sides of dialysis and transplant. She was on dialysis for almost a year or so, and then now she's touchwood doing post transplant, almost hitting 5 to 6 months, and you can see the quality of life that she's leading. I mean, I'm sure she's back to conducting more of these discussions now post transplant than she was pre transplant.
Yes, doc. Thank you for that. Yeah. So, since we've started talking about transplant, that was where we were going next. What are the unique considerations while preparing a lupus patient for a kidney transplant? There was a lot of desensitization needed in my case, also due to blood transfusion and stuff. So, yeah, a bit about that.
So, two major considerations that we generally, or two hurdles that we encounter when a lupus patient is going to undergo a transplant is, first of all, lupus comes with anemia and low hemoglobin at some stage during the disease process. So you would have received packed red blood cell transfusion, and that comes from random donors. So when you get exposed to the antigens, or when you get exposed to blood from random donors, your body tends to develop antibodies, and those antibodies can play a hindrance in your transplant. And you would have to give more immunosuppression and something called plasma exchange, which is like dialysis, but it has a filter which helps remove those antibodies. Then because it's an autoimmune disease, you tend to develop these autoantibodies which can interfere with your cross match tests. But now the cross match tests are quite advanced, and we can differentiate between culprit antibodies versus autoantibodies. We can remove those antibodies because those autoantibodies carry no risk of rejection with it. So that anyway is a more technical hurdle that we have to face, which we are able to overcome over the last few years with the advancements in the cross match techniques. But the first hurdle that I mentioned about, that is antibodies, because of exposure to these human products before, increase the risk of developing antibodies, and which could impact the transplant kidney because of rejection and things like that. But now we have enough medicines to suppress that also. And the second is, see, transplant also involves usage of immunosuppression. And during your lupus also, we have given so much immunosuppression. So, over time, the cumulative immunosuppression that is used is quite a bit. So it's very important that when we take a decision to transplant you, we vaccinate you against a variety of diseases that we think is important and as per the guidelines. Like Suzanne, in her case, received almost 4 different kinds of vaccines that we gave her in her pre-transplant period. Because if you don't vaccinate them, post-transplant, you're on high dose of immunosuppression, your immunity will not develop any immunity against the vaccines that we're giving. So we stress upon vaccinating pre-transplant.
Thank you, Doc. That was a really detailed explanation. Also, could you talk about what the success ratio of kidney transplant is specifically for lupus patients? This is something that also comes up very often. And what are the chances of lupus coming back after a kidney transplant?
Yeah, that's a very frequently asked question, whether this problem will come back, not just in lupus, but anyone who's had something called vasculitis also, and anti-GBM disease and a bunch of other diseases. People ask, oh, will this come back in the new kidney? First of all, the success rate in lupus patient undergoing transplant versus any other patient undergoing transplant now overall worldwide, or be it at our center or whatever, is around 90 to 95%. So success rates for transplant way back in the 1950s was only 40 to 50%. And we have come a long way because of the advancements in the medications and all other testing that we do, that the success rates are around 90 to 95%. So that's the first answer to your question. The second thing is, see, lupus needs immunosuppression, transplant needs immunosuppression. So even if the lupus was to recur, we are already giving the medications preemptively to prevent recurrence. So chances of lupus recurrence are as less as 3 to 4%. So some books mentioned up to 5%, but the chance of recurrence of lupus per se is quite less.
Thank you, doctor. That's a really reassuring answer for a lot of us. And like you mentioned, we've been on a lot of immune suppression way before transplant, also just to treat the lupus. So how does this impact healing and recovery after transplant?
Healing per se, not so much. Yes, I mean, because you've been immunosuppressed for so long, we are always wary about infections. But as I mentioned, we put you on antifungal, antibacterial, antiviral, and vaccinate you to prevent the chances of infection. Steroids do affect wound healing, but there have been so many advances in the surgical process also. Like the wound that is given, the incision that is given for transplant is smaller now. Now you have robotic transplant also, which where it is just like a keyhole surgery. So you will have at the max like a centimeter or 2 centimeter cut. So healing also, those steroids do affect wound healing. With all the progress that we have made, healing is as good as a normal individual, and immunosuppression doesn't affect as much.
Thank you, Doc. Last question in this section. Can you talk about like the overall kidney care lifestyle management for a lupus patient post-transplant? Again, I know this is similar to any sort of CKD patient who's gone through transplant, but just for us to hear that.
Yeah, so I mean, we split the transplant period into first 3 months and then 3 months to 1 year and then 1 year and beyond. So the first 3 months, because you've had a new kidney, the body could identify it as foreign. The chances of rejection are maximum during that period. That's why we start you off on high dose immunosuppression and then slowly cut down on your steroids and try to manage your TAC levels and things like that. Tacrolimus levels in the first 3 months needs to be between 8 to 10, and then subsequently between 5 to 8 is roughly acceptable. And then we limit your interaction or how much you go to public places in the first 3 months. We try to prevent you to go out to crowded places. We ensure that you've been masked and things like that. And because of the side effects of these medicines like tacrolimus and steroids have increased chances of having a higher blood pressure, increased chances of having higher blood glucose levels and becoming a diabetic. We are quite aware about that, and we keep monitoring your sugar so that you don't become a diabetic. And if you become a diabetic, which can happen in roughly 10 to 20% of the people, we start you on medications right away so that your blood pressure remains controlled.
Thank you.
And sugar remains controlled.
Sorry. Yeah, thank you, Doc. So with that, we've reached the end of our session on lupus and kidney. And in conclusion, I would just like you to comment on the importance of, regular follow-ups and having that proper accessibility to your doctor, especially checking for smallest medications that you're going to take, because a lot of meds unknowingly can, impact the new kidney as well. So just the importance of being regularly in touch with your doctor.
Yeah, I think, I couldn't stress on it more, especially be it whether you are a lupus patient or a post-transplant patient. Many a times you must have noticed that once your doctor has kept you on some medication, then they call you back for follow-up within 2 weeks or like a month. And then they see those reports and they're like, everything is okay, continue the same. And you're like, dude, why did I really do this? Do I really need to go? But what is important is, see, the juggling with immunosuppression would happen in the first 2 to 3 months. After that, once you've hit the sweet spot, and your disease activity is relatively under control, then the whole idea is to continue this medication. As per the guidelines, they say 36 months of MMF should be given in the lupus patient I'm talking about. I'm not talking about post transplant anymore. At least 3 years of treatment has to be given. So you would be on follow up for 3 years, and maybe monthly or sometimes 6 weeks or 8 weeks. But the whole idea is of frequent follow ups is that if the lupus is coming back, or if the activity is increasing, if the creatinine is increasing, if the protein is increasing, to pick it up at the earliest. You could be like, I'm on stable immunosuppression. The doctor hasn't changed medicines in the last 6 months. Do I really need to go? I'll go after 3 months. But he called me after a month. He or she called me after a month. It is important that you go after a month, because it's not necessary that you have any symptoms per se. Before, as I said, the lupus could be increasing here. Let's not delay it as much that you detect the flare much later. If it's increasing here, it should be detected here, or ideally here, so that your steroids or your MMF can be increased and the disease activity brought down under control again. So I couldn't stress on the importance of follow-ups anymore. And yeah, it's always good to run any new medication that you're taking with the rheumatologist or nephrologist, whoever you are following. Many a times we have some ankle sprain or backache, and then we go to the local doctor who may not be too well versed with managing your issues, may end up giving you some painkiller which is not kidney friendly. So it's important that you just ask your doctor, hey, he's written for this, is it okay? And I mean, get that green light for that medicine.
Yeah, thank you, Doc.
And there are many talks also about alternate form of medication. Ayurveda or homeopathy is a science which I am not well versed with, so I wouldn't comment on its efficacy on controlling, lupus activity. There are many a times where we have seen patients come to us and be like, okay, and they suddenly vanish for 2 months trying some alternate medications, and then come back saying that no, this problem still persists. So again, my argument here being that if we knew there was a diet, or if we knew there was an alternate form of medication which helps you control lupus, we would be the first people to suggest that ourselves.
Yeah, thank you so much, doctor. Especially, I think I'm a testimony to this, coming to you very regularly, just asking, is this okay? And then, you patiently responding to that. So definitely, that's a really important aspect of this. So, yeah, thank you so much, Doc. This was such an insightful session. Do we have another 10 minutes of your time?
Yeah,
Just
yeah. We'll run through all the questions
yeah,
that have been asked here. I think Haripriya's question was already answered, which she asked at 5:17. Then Gaurav Kaur asked one question which was already answered. Then Anusha has put in class 3+5, and but I don't know the context of that right now. Gaurav mentions about his wife undergone cyclophosphamide, but it didn't work well. Protein leakage is also 1,500. So, I mean, as I said, there are various modalities available to control lupus, be it cyclophosphamide, be it MMF, be it tacrolimus plus MMF plus steroids. So if one modality has not worked, we have to switch to the other. So it's trial and error. Which patient is going to respond to which modality? Even we don't know as your doctors. It's only after we start it and we monitor you, do we understand, yes, okay, this is getting under control, this is not getting under control, or this is getting under control, we need to prolong it a little further. So that is only through trial and error. So that would be my answer to Gaurav. Aarti has asked, hello, sir, in case we are cleared by our doctor to go ahead for pregnancy, what are the chances the child may have lupus? Lupus is not a genetically transmitted disease. That is something that you need to understand. It is more incidental and sporadic, which happens because of our genetic background interacting with the environment that we are exposed to. So it's something called epigenetics, which I'm not going to get into the details of right now. But what you need to understand is, if you are a lupus patient who's planning a pregnancy, please don't worry about your child having lupus. Go ahead. Though, again, if you Google familial lupus nephritis, you'll have a few examples. But again, I would like to reassure you that it is not a genetic disease. Then Digambar, who has asked.
Interruption. We also have a session later on lupus and reproductive health. So any other questions on this topic, we will address it later. Yeah, go ahead, Doc.
Okay. So there is any major role of food in lupus? I think we I think we covered that in extensively. GK has asked, can regular urine test of spot ratio help in preventing kidney involvement? Yes. I mean, I'm sure the doctors who are following you up are looking at your urine protein creatinine ratio on a regular basis to understand if you've had lupus, whether it is still under control or getting controlled, or if you've not had lupus nephritis, whether there is any kidney involvement. So it's absolutely essential that you get your creatinine, blood pressure, and urine routine and urine PCR check every follow-up. Haripriya, what is the likely prognosis of the class 4 if there is no chronic damage at the time of diagnosis? How long can it take? So if there is no chronic damage at the time of diagnosis, you've had class 4, but you have given appropriate immunosuppression with achieving remission or appropriate response, then I don't see why you should progress to end-stage renal disease. Obviously, monitoring would be required, but you can be rest assured that you will not reach a stage of severe CKD or dialysis. Priyanka asks, my SLE nephritis has been under remission last few years and there is rising ANCA titers. I don't know if that's a typo and you meant ANA titers, because ANA is what is used in lupus nephritis. ANCA is used in a completely different disease called ANCA vasculitis. However, a rising ANA titer doesn't necessarily mean that your lupus nephritis is coming back. Along with the ANA titer, we look at something called dsDNA, which is a marker of lupus activity. We look at complement levels, that is C3 and C4. And if these are decreasing along with a rising ANA or dsDNA positive, then it could mean that your lupus is still active. Doesn't necessarily mean that your lupus nephritis is active. dsDNA is applicable to lupus nephritis. But if any of this is happening to you, I would want to tell you that you should visit your doctor, get C3, C4 also check, get your urine protein check, creatinine check. So it's important that you follow up. Mrs. Dharmishta has asked that about her son who is an SLE patient and his biopsy showed class 4A creatinine 1.3, 2 plus protein, normal BP, ultrasound shows mildly increased. What does it mean? How to care for him? Again, I mean, this becomes a medical consult. This might not be the right platform to discuss this. But obviously, if you've undergone a biopsy, it means that you're showing a certain doctor. I would want you to visit that doctor. Ensure that you are on immunosuppression. Okay, if obviously being class 4, it's very important that you're on immunosuppression. If you're not, then please speak to your doctor about the need for immunosuppression. And your disease activity needs to be controlled. The urine PCR needs to be checked, and you need to ensure that the urine PCR comes below 0.5. Does lupus? This is a very common question where everyone took the COVID vaccine, and some people developed some complications later in life, and a lot of blame was given to the COVID vaccine. What I want to tell you guys is COVID was a pandemic. COVID was something which was unfortunate. Many lives were affected, many families were lost, and it was absolutely essential that we all got vaccinated against COVID and took the COVID vaccine. The effects of COVID on immunity is a completely different discussion in itself. But from what I've read and what I know, the COVID vaccine per se doesn't precipitate any form of lupus. Dheeraj also asked, what is your recommendation for young age girl with early diagnosis of SLE? Does affect on organ?
So we can move to the next one, perhaps.
Yeah. Sometimes important medications such as patients, Septran, tacrolimus are themselves nephrotoxic. Yes, but they are essential. What do we do? It's as lupus, as Susan said, that it's a double-edged sword, but we need to look at the risk and benefit. Septran is protecting you from infection. Tacrolimus is protecting you from lupus activity.
Or maybe
Prashant has
one
said,
more
my
question.
question pending. I didn't get Prashant's question actually. Maybe that was when I was logged out.
That's fine. Doc, we'll take one more question and maybe end the Q&A round. It's starting to turn into a bit of a consultation mode with very specific
Oh,
numbers that
yeah.
are being talked about. So maybe one more question, which is around, yeah, does it mean immune suppression is higher? Oh no, okay. Some question about shingles.
Yeah.
Yeah, can you catch
Higher.
if immune suppression is higher?
So, I mean, many people ask us, we've had shingles before, should we take the vaccine? Yes, you should take the vaccine because the chance of recurrence of shingles is 60%. If you've taken the shingles vaccine, can we get shingles again? Yes, there is a 10 to 15% chance because the efficacy of the vaccine is around 80 to 85%. So, yes, you could get it, but you should take the vaccine because it's better to have a 15% chance of getting it than a 100% chance. So,
Okay. Thank you, Doc. I think the rest of the questions are, yeah, please maybe talk to your doctors with very specific, numbers and reports. So with that, we'll end the Q&A session and also this really informative webinar. I would like to call on Priyamvada, who is our lupus patient leader here in Karnataka as well. So to give the vote of thanks. Over to you, Pri.
Good evening, everyone. Thank you so much, Dr. Fahad, for this enlightening session on lupus and kidney. Your deep insights, clarity, and compassionable approach have truly enlightened us all. Your support for patients and eagerness to contribute to the lupus community is truly precious to us. Thank you for taking out time, and this was a very energetic session, and throughout engaging with patients and the question, answering every question so diligently. Thank you so much. I would also like to thank our participants and attendees who joined us from different parts of the world and for contributing for such an insightful session. We hope we could add in some meaning and y'all could gain some knowledge out of this session today. A big thank you to our organizing team and volunteers of Lupus Trust India. Thank you for lending your hearts and support for this awareness and the campaign this year. It has been wonderful so far and very meaningful too. As we move ahead for the remaining webinars in this series, we look forward for your continued participation and enthusiasm. Let's keep this conversation going, spread the awareness, and work together for a better future in SLE. With this, I would also like to conclude by inviting the president of Lupus Trust India, Ms. Vachasamrita, to also give in a word of thanks from the institute and her behalf.
Good evening, everyone. Good evening, Dr. Fahad. Good evening, Susie.
Great.
Thank you very much for doing this today. Throughout the session, I sat through. I was just sitting right next to Priyam here. We had a Lupus Day event here at Kochi, and I was just telling her how like she said, it felt so energetic. It felt like you were somehow sensing the pulse of what our patients would want to hear. And Susie, to you, thank you for addressing such a broad spectrum of questions and topics that we need to address with regards to lupus nephritis. And Dr. Fahad, thank you once again on behalf of Lupus Trust India, and we hope to continue receiving your guidance and support throughout.
Thank you. And I would love to be part of any sessions in the future. Thank you, Susan, for this opportunity. And I would just like to end it by saying many of you who are patients yourself here or have loved ones who are lupus patients can always ask yourself, why me and why has this happened to me, and uh, why go through this? I want to tell you that there are a lot of medications which can help control it, and you all are true fighters, and keeping yourself motivated day in and day out to have a better future, and having trust in your doctor and the medications that are being prescribed. Sometimes it could get a little frustrating when someone tells you that no, you have not responded enough, or you need a change of treatment. My last few words to you would be: hang in there. There are a lot of medications coming in with a lot of promise. There are already a lot of medications present which will help control your lupus. But do know that we understand where you are coming from and your frustration, but we honestly believe that all of you are fighters, and you really inspire us. I look at Susan, I look at other lupus patients that I have, and people complain about a few niggles here and there and problems in their life, but to walk into the OPD room with a smile that she has on her face day in, day out, with all the problems that she's already faced, I think that is very inspiring and very motivating, and it has made me a better person. So thank you to all of you, and I wish you only the best, and have a great future ahead with your lupus definitely under control. Take care, everyone.
Thank you so much, doctor. We really appreciate that. Thank you. And thank you, everyone. There's a lot of thank you messages in the chat box as well. So
Yeah.
we're all very happy to have you. All right. Thank you. Good
Thanks,
evening.
Susan. Thanks, Lupus Trust India. Yeah. Have a good evening, everyone.
See you. Bye.